Okay, this is a podcast lecture on the science of ACLS and CPR as part of our ongoing iPad project to teach crisis resource management and ACLS. So basically in this lecture I'm going to give you some background on why we do what we do with CPR, how it works, and why the things are important to maximize effective CPR. So some very basic background. So cardiopulmonary resuscitation, or CPR, was first developed in the 60s, formally adopted by American Heart in 1968, where they developed the mnemonic ABCs, or airway breathing compressions. Through outreach to the community, they were able to train the lay public on effective CPR as well as healthcare providers. And then there was a realization that in addition to just CPR, the American Heart Association also needed to help create guidelines to treat the medical component of a cardiac arrest, and they developed what became advanced cardiac life support for healthcare providers, giving them the education, the guidelines, and the evidence-based practice to be a successful resuscitation expert through ongoing education and training. Important to note that the ACLS guidelines were revised by a steering committee made up by experts in the field of emergency cardiac care, and they revise the guidelines every 5 years. So every 5 years we have a new guidelines where they review the most recent data and the studies and make changes. The guidelines that this app is based on are the 2010 guidelines. So these are the most up-to-date at the time of this app's development. Now they go through and create different recommendations. This is similar to other advisory bodies, but a class 1 recommendation: the benefits greatly outweigh the risk, and this should always be done. Class 2A, the benefits mostly outweigh the risk, and it is reasonable to do. Class 2B, once again, the risk greater than benefits greater than the risk, and this may be considered by the providers. And then Class 3, risk outweigh benefits, and this should not be done. So most things fall in the two areas. There's some clear Class 1 recommendations. Interesting to note, CPR and defibrillation are the Class 1 recommendations for cardiac arrest, as well as continuous CO2 monitoring. All the others, all the other drugs, everything else falls in the 2B categories. And some of the drugs that have been removed and some of the techniques in Class 3 obviously are no longer in the guidelines. So let's first talk about the theory of how CPR works. There's two different models actually, and it's maybe that the is overlap. In reality, there's conflicting data as to which one is maybe the most correct model, but it helps you get a framework about how CPR works to think about these two different models. So there's a cardiac compression pump theory and the intrathoracic pressure pump theory. So let's go over the cardiac compression pump theory. So that's basically kind of what people think about. You push on the chest, the heart is compressed against the sternum and the vertebral column, which physically pushes blood out, ejects blood out of the aortic valve. As the chest and heart expand because of the elasticity of both the chest wall as well as the vascular and the heart and structures, blood is pulled back into the heart and then ready to be pushed out again, a very kind of mechanical, if you will, piston-driven pump. Coronary and cerebral blood flow occurs just as though it would occur during a normal physiologic state, it is thought, in this cardiac compression model. Now, compare this to intrathoracic pressure pump model, where the chest compressions cause a rise in intrathoracic pressure. This pressure is transmitted to the arterial but not to the venous side of the extrathoracic vessels. And this pressure difference causes blood to flow out of the thorax. So you create compression down, creating pressure, and then causing a pressure difference, pushing blood out, and then the negative intrathoracic pressure from the recoil pulls blood back into the venous side, and then pushed out with conjection, with compressions. The release will cause the venous blood to return to the thorax, and coronary blood flow occurs in a retrograde fashion during chest recoil or relaxation. So blood is flowing out, and then when the chest is allowed to recoil, blood then flows retrograde down the coronaries. So myocardial flow is the primary determinant of survival from cardiac arrest. No matter what, if you can't get flow to the heart's not going to stop. It's not going to start ejecting or having organized rhythm. Now, clearly, you need cerebral flow as well to suffer, so that you don't suffer neurological injury. But you're never going to get them back without flow to the heart. So the amount of flow to the coronaries is predominantly dependent on the amount that the chest is compressed, because that is how you generate this flow, either in the forward flow from the direct compression, or the retrograde flow occurring from the intrathoracic pump model. Both require coronary flow and both require chest compressions to create that coronary flow. Now, a rate of 80 to 100 compressions per minute provides for about 50% of the time being during a compressive phase, which is optimal for blood flow, allow refilling. Now, there's some data you can say, well, I'll tell you in a minute, the guidelines are actually greater than 100 a minute. This is probably because you need to overshoot in order to hit the critical period. We know that any rates below 80 are incredibly suboptimal, probably ineffective. So if you want to push it to 100, because if you dip into the 90s, then you're still in a good range. There's some data to say even faster flows, faster heart compressions of 120 may even improve the amount of forward flow in the coronaries, especially if you believe the intrathoracic model for coronary perfusion. But the general idea is you want to push at least 100 times a minute. Really get this blood circulating by doing brisk compressions. Now, basic cardiac physiology, if you remember, cardiac output is the heart rate times the blood pressure. Blood pressure is a component of both the stroke volume and the systemic vascular resistance. Now, ideal CPR, meaning as good as you're ever going to get, only produces about 25 up to, at very, very best, 40% of pre-arrest cardiac output. So you're already dealing with a very suboptimal cardiac output here compared to a normal physiologic state. So it's absolutely important that you have ideal CPR in order to get even that 25%. So how can you do that? So if we go back and look at the physiologic waveforms, or the physiology determinants, let's look at what we can control. So heart rate, obviously, we're going to become the heart rate by doing the compression rate. Once again, greater than 100. Stroke volume, so it's how much we compress and allow recoil of the chest. Now, there's a sweet spot here about adequate compression, because if you push too hard, you may create trauma, which can cause adverse events. If you especially resuscitate this patient, if you have lacerations to the liver, the lungs, pneumothorax from broken ribs, etc. So you want to be kind of Goldilocks theory, if you will. You want just a right amount of depth, but typically about 2 inches depth to create that stroke volume. And then your systemic vascular resistance, you're going to have to probably augment that, especially as the arrest moves forward. Initially, the brainstem under an arresting state is going to have an outflow of sympathetic activity, which will help maintain the systemic vascular resistance. But over time, as the brain becomes ischemic, the brainstem starts losing that ability to control the sympathetic outflow. The vasculature is going to start dilating, so your systemic vascular resistance is going to start falling, making the blood pressure and corollary cardiac output fall, which will decrease your coronary perfusion. So especially as the resuscitation progresses, you're going to have to support this, and typically this is supported with vasopressors, which we'll talk about. So let's think about what happens when the patient goes into cardiac arrest, for the classic example of ventricular fibrillation. So the minute the patient goes into ventricular fibrillation, there is no ejection from the left ventricle. You have no organized contraction, so immediately you stop all forward flow across the aortic valve. So the pressure that's in the aorta, and the pressure in the left ventricle, and the pressure in the left atrium, pulmonary veins, pulmonary artery, all this starts flowing down the pressure gradient. So you've got pressure higher on the arterial side than the venous side. But as that pressure equalization occurs, blood starts flowing down. Instead of being pushed from the venous to the arterial, it starts flowing back from the arterial to the venous, which causes all that blood in the lungs to pool, but then eventually start filling the right ventricle and right atrium, which causes dilation. Now this is important because as the ventricle becomes dilated, the myosin-actin relationships get stretched, making the harder to get a good organized contraction if you're able to defibrillate this patient back in a sinus rhythm. It's also the geometry changes so that you're having a harder time to get adequate electricity across the ventricle. So all these things say basically what we need to do is we need to do good CPR to not only get forward flow and keep coronary perfusion good so we can keep the heart happy, we also have to unload that right ventricle so that it's not dilated. If you remember, the right ventricle is a low pressure system, does not like to be dilated, does not respond well to acute dilation. So doing compressions, you're able to get that blood moving forward and decompress that right atrium and right ventricle. Therefore, you have a better chance of successfully defibrillating the patient. It's important. The reason I'm stressing this is that unless you're able to defibrillate very, very quickly, you need to do compressions and get that blood out of the ventricle, and also keep the coronary perfusion so that there's adequate ATP for mechanical contraction and ejection. So how do we best assess the coronary flow during CPR? So relaxation pressures during CPR is the trough of the pressure waveform during relaxation phase of the chest compressions. So it is basically analogous to the diastolic pressure when the heart is beating. So when you push down and then relax, the lowest pressure that registers, if you had an arterial wave ability to monitor the arterial wave form through an arterial line, that's the relaxation pressure. Now the gradient between the right atrium and the aorta during the decompressive phase of CPR is described as coronary perfusion pressure, because that's when the flow is occurring. So anything you can do to raise the aortic pressure or anything you can do to lower the right atrial pressure will improve coronary flow during CPR. Now that's important, so I'm going to say it again. Raising the aortic pressure or lowering the right atrial pressure will improve forward flow into the coronaries. Now, you can raise the aortic pressure by using vasopressors, and you can decrease the right atrial pressure by doing good CPR, unloading the right atrium, and by not overventilating, which transmits positive pressure into the intrathoracic space, therefore creating higher right atrial pressures and making that gradient worse. So overventilation is a problem for many reasons, which we'll talk about. And That's another key idea to understand when you're doing CPR, and this is why breaks in CPR are so detrimental. So as no flow occurs in the coronaries, the coronary tone, the blood vessels have a certain contractive nature because of the elastomericness of the vessels, and they're going to collapse on themselves. And it's only after you've been able to create enough pressure head to pop those vessels back on, if you will, that you're going to get flow in the coronaries. Now usually this is 30 to 40 millimeters of mercury, but under maximum dilation, which tends to occur during the ischemic period of an arrest, you may be able to get it down to 5 to 10 millimeters of mercury. But either way, that means that that's the amount of pressure that you have to generate in those coronaries before they'll even open that will allow forward flow. So every time that you stop compression, that goes back to zero. Then you've got to create that forward flow again by doing effective compressions to build that pressure back up in the coronaries and get the flow going. So every time you stop, flow stops, vessels collapse, you got to start compressing again, and it's not just the first, it's several compressions in before that flow starts going. That's why it's so detrimental to have breaks in CPR. This pressure at which the vessel closes is just known as the closing pressure. And like I said, it may be up to 30, 40 millimeters of mercury, so you really need to keep that pressure going. And we'll talk about at the end how to assess for that. And using the diastolic pressure on your arterial waveform during compressions, that's going to be an indicator of what kind of flow you're getting in the coronary. So once again, don't stop compressions because you're going to have zero flow, and it will take a while to get that flow reestablished once you resume your compressions. So this reason about breaks in CPR and research showing that patients, may not need very much oxygen in the resting period, may not need much ventilation in the resting period, have resulted in a new recommendation. These are new guidelines for 2010, replacing the old ABC. So no longer is it airway breathing chest compressions. It is now CAB, which is compressions, and then you do the airway, and then you do the breathing. Because the vast majority of arrest, it's going to be ventricular fibrillation, especially in the out-of-hospital setting. Those patients had a sudden rhythm change. They likely have an adequate amount of oxygen in their blood. Their extraction is very low at this point in an arresting circumstance. The priority is blood flow, not oxygen or ventilation. Now, all these guidelines are modifiable, so important to note about any of these guidelines. It's not set in stone. You use your own judgment at that moment. So clearly, if this was a patient that was having a preceding respiratory arrest, then you're going to maybe start ventilating before compressions, for example, like a choking. But most of the case, these are PEA arrest or these are VFib arrest. So you go in and find the patient. First thing you should do when you have no signs of perfusion, immediate start chest compressions. And then you can move to checking the airway and ventilating the patient. The lay public is actually being taught to do no ventilation, just compressions. Once again, the thought for this is that A, people won't do it, B, they waste time doing ventilations rather than compressions, and C, ventilation and oxygenation is a lower priority than the compressions, at least in the early phase. They can ask, should I just never ventilate patients? Well, studies have shown that in the arresting patient, especially in the inpatient setting, eventually you need to ventilate and oxygenate these patients. But that comes after you do effective compressions. So let's talk about effective compressions, because this is really the key. ACLS is really only successful with good basic life support. This is where you sink or swim. So it's very important. So what makes good high quality CPR? So you want compression rate of at least 100 a minute. Once again, at least 100 a minute. You want the depth at least 2 inches. Ideally deep enough to have a physiologic response, which I'm going to talk about how you can monitor that in a minute. You're going to want allow complete recoil of the chest. Once again, this is very important. If you're leaning on the chest and not allowing it to fully recoil, then you're not going to get the maximum flow and also get the maximum return of blood to the thorax. You have to rotate your compressors every 2 minutes. The reason for this is doing studies on using mannequins where you can completely and assess the quality of the CPR. People start wearing out pretty quickly. They definitely by 2 minutes their effective rate of CPR has fallen off dramatically. They are able to often maintain the adequate rate, but their depth starts falling. They're not able to go as deep, and they start leaning on the chest. Both things adversely affecting the quality of the CPR. So get in the habit. Rotate everyone every 2 minutes, no matter what. Don't wait for them to say they're fatigued. Assume they're fatigued, because actually people have a poor ability to self-monitor. So you as a leader just need to rotate everyone every 2 minutes. But when you rotate, you make sure the person's ready to go, so there's no delay. So it's boom boom as you transfer compressors. You're going to limit all interruptions in CPR to less than 10 seconds. So that means pulse checks, rhythm checks, interventions. Nothing should take longer than 10 seconds. Nothing is more important than effective CPR. So really focus on never interrupting, and if you do, make sure you get them right back on the chest as fast as possible. You want to ventilate 8 to 10 breaths per minute. Now this is important because, once again, if you overventilate, you decrease the effectiveness of CPR, which we'll talk about in a moment. So as we talked about, rescue fatigue results in inadequate rate and depths. So change them out. Even if they don't feel tired, change them out. Avoid overventilation. This is something, as an anesthesiologist personally, I know it's very easy to do. People are excited, their adrenaline's pumping, they're bagging the patient aggressively because it's what you do. Worst thing you can do for an arresting patient. You really got to monitor your airway person to make sure that they're not overventilating. The goal is 8 to 10 breaths per minute. The average, 30. People will squeeze that ambu as fast as it refills. Absolutely detrimental to the patient. In addition to a breath rate of 8 to 10 per minute, you also want to avoid large or long breaths. Both of these create a negative effect on intrathoracic pressure by creating, sorry, kind of stated inappropriately here. It creates a positive pressure effect in the chest, which allows, decreases the flow to the coronaries, decreases venous return, and adversely affects the quality of the ejection. Consider every time you give a breath that your output is going to go to 0. So if you're ventilating 30 times a minute and you're compressing 100 times a minute, you're going all out. You're the best compressor in the world. If your ventilator is going 20 to 30 times a minute, your effective rate is going to be in the 70s. Way too low. We said 100 is what you desire. 80 is, you might as well not even be doing it. If you got someone breathing 30 times a minute, they've already screwed you with high quality CPR. So really monitor the ventilator for this. And a tidal volume of 500 to 600 is adequate. You don't need to give high tidal volumes. You're just basically trying to oxygenate these patients. If they're hypercarbic on the gas, you got to fight against overventilating. Even if you're at metabolic acidosis, work on the quality of the CPR to improve that acidosis. It's probably because of poor perfusion rather than underlying acidemia. And even if it is, you can't rely on your ventilation to help improve the acid-base status of these patients, because you're going to undercut the primary effectiveness of CPR. So how can we assess how well we're doing with CPR? I've alluded to this before. These are new 2010 guidelines, continuous physiologic assessment of CPR. Now the easiest way to do that is doing continuous CO2. But as you get additional resources there, you can actually assign someone to place an arterial line, which also gives you valuable information. So the ability to monitor both of these would be ideal, but let's talk about each one individually. So end-tidal CO2. So normal conditions, the end-tidal CO2 ranges from 35 to 40 millimeters of mercury. You may ask, what is end-tidal CO2? So basically, as we exhale, we obviously exhale CO2. So you can actually quantitatively assess the amount of CO2 coming out of the lungs. And we call it end-tidal because that's the end of a tidal breath. So CO2 is rapidly diffusible. It's rapidly going to rise as the patient exhales. And the last measurement before you get the next breath, that's your end-tidal CO2. And it is about 5 to points lower than your PaCO2 if you were to do a blood gas. There may be higher gradients depending on underlying physiology and VQ mismatch, but in general, let's assume that that's a approximation of the PaCO2. Now, you're not necessarily using it as a mechanism to monitor ventilation. You're using it as a mechanism to assess perfusion. Now, if you're perfusing the lungs, CO2, which is so rapidly diffusible, is going to come out. If you're not perfusing the lungs, it's not going to come out. So you're really using it as a secondary marker for perfusion. If you have a normal patient with a good output and you're monitoring CO2 and you suddenly drop the cardiac output significantly, the CO2 is going to fall. It's just like in the arresting circumstance. If you get good compressions, good ventilation to the lungs, good perfusion to the lungs, good perfusion to the heart, that CO2 is going to climb, and you're going to say, okay, I'm doing a good job with my perfusion. And animal studies have shown that end-tidal CO2 correlates with cerebral perfusion pressure and coronary perfusion pressure. So what do you look for? So we know that persistently low end-tidal CO2s, meaning less than 10 millimeters of mercury during CPR, means that return of spontaneous circulation is very unlikely. So if you see this, you really got to boost it up. Or if you're unable to boost it up and you're persistently low, consider that your resuscitation may be at its end. Now, monitoring end-tidal CO2 once again gives you the ability to assess, am I doing adequate compressions rate? As the CO2 is good and it starts decaying, you can say maybe the rescuer is starting to fatigue and you may need to switch them out. You may need to give vasopressors if you're not able to improve the CO2 with CPR. And an abrupt sustained increase in end-tidal CO2 during CPR is a marker that maybe the patient's getting a return of circulation. So this will allow you to not have to constantly stop and do pulse checks, which we know are detrimental. If you suddenly see an increased CO2, then you've got a better idea that maybe the patient's pulse is coming back, and then maybe at the next cycle you'll be more comfortable assessing that the patient has a pulse or not. It's also important to know that you can use continuous CO2 to maintain both the adequate placement of the endotracheal tube and also adequate confirmation that the tube stays in the trachea. Patients being compressed, there's lots of motion. Last thing you want to do is have that ET tube come out and end up in the esophagus again, or end up in the esophagus when you think it's in the trachea. So you want to make sure that you are assessing that continuously. So you get many reasons to use end-tidal CO2. You should make sure that your co-team has this capability. A lot of critical care transport monitors have these capabilities. They should become more readily available now that these are level 1A recommendations. So make sure you know where and how you can do continuous CO2 in an arresting circumstance. So this is once again level 1, new 2010 guidelines. If your end-tidal CO2 is less than 10, it is reasonable to consider trying to improve CPR quality by optimizing chest compression parameters, meaning change compressors, push harder, make sure you're going at the appropriate rate, or using a vasopressor such as epinephrine or vasopressin. So what's the other way to measure the physiological assessment of CPR? So as we talked about before, arterial laxation, or the diastolic pressure, if it's less than 20, it is reasonable to consider trying to improve the quality of CPR, once again by optimizing chest compressions, or giving a vasopressor, or both. So if you have arterial access and you're able to monitor, and your diastolic with recoil is less than 20, you need to intervene because your adequacy of CPR is not good. Now, once again, you can also use this as a marker for the return of spontaneous circulation. If suddenly the pressure that you're generating with compressions suddenly increases above where it's been, it looks like there's competition, then that means that the patient's having an ejection on their own, and they may start having adequate perfusion. So I'm using it as a marker rather than pulse checks. We know pulse checks are very hard to do. We know that people are often unable to assess adequacy of pulse, and it takes too long. So really get out of the habit of doing pulse checks. Really rely on other signs that you've got return of spontaneous circulation rather than doing the constant pulse checks, which aren't effective and likely will result in delays in CPR. Now, where do you place these femoral lines, arterial lines? Give me the femoral artery. Often those are easy to access during compressive CPR. You can try the axillary or brachial artery. I encourage people to get an ultrasound and image the groin. That way you know which one is the artery, which we place a large venous line in the vein. Going just off pressure, often because of the way the flow and the pressure is transmitted to the venous side with compressions, you may actually be palpating the venous structures and feeling that that has a pulse versus arterial. So, portable ultrasounds are pretty readily available. Encourage you to get one and use it for placing these lines. Once again, you're not going to place the lines as a leader. You're going to assign that task to someone else. But often you have extra hands at these things that might be able to help you with invasive monitoring. So vasopressors have been associated with improved coronary and cerebral blood flow with CPR, especially after the first few minutes where the sympathetic tone of the patient starts decaying because the patient's brainstem is getting ischemic. The gold standard is epinephrine. So all arresting patients are going to receive epinephrine no matter what the cause. Asystole, PEA, VFib, VTAC. If they're pulseless, they're going to get epinephrine. Now, epinephrine is both direct alpha and beta sympathetic stimulant. It activates the receptors directly, causes vasoconstriction, both the coronary and cerebral vasculature, which helps maintain a better pressure head, therefore improving flow. It increases myocardial contractility through the beta, which may help in a failing ventricle. But it does have some adverse components. It will increase your myocardial workload, and higher doses can result in toxicity. So we do not escalate epi like we used to. It's a single dose of 1 milligram every 3 to 5 minutes. So it is reasonable to consider administering 1 milligram dose of IV or intraosseous epinephrine every 3 to 5 minutes during an adult cardiac arrest. If you haven't gotten them back within a minute or two, if it's a VFib arrest, give the epinephrine before the next shock. If it's a PA arrest, you're going to give the epinephrine right away because that is, all the treatment plans are to support perfusion at that point. Asystole, obviously, once again, going to give milligram right away with the compressions. Now, there is an alternative which also causes very potent vasoconstriction. That's vasopressin, and the dose is 40 units IV. Its half-life is about 20 minutes, but you are going to use it just one time, and it shifts blood from the peripheral circulation to the central circulation, therefore increasing the circulating volume. It also increases cerebral and coronary blood flow during CPR in animal models. It does give us what we need to help maintain a coronary and cerebral blood flow. So one dose of vasopressin, 40 units in the adult, either IV or IO, may replace either the first or the second dose of epinephrine in the treatment of cardiac arrest. So they give epi followed by vasopressin, or give vasopressin followed by rounds of epi. You decide, but typically it's good to try both agents. But vasopressin, you're going to use a single time. Advantage of vasopressin is that there's no effect on the myocardial contractility, therefore it's not going to worsen the myocardial oxygen demand. It may be a good choice in a patient who's having an MI and then has a primary ventricular fibrillation arrest. Maybe you'll consider using vasopressin first versus epi. But really understand that both are used. You can use either one as your first-line agent, but the key is to get it in and circulate to help maintain the coronary and cerebral tone. Now there's things that have been developed to assist in CPR